Hello everyone, welcome to another session of pathology. Let us continue with the second part of the third chapter, inflammation. Today we are going to discuss about the mediators in inflammation. So far we have discussed what are the causes of an inflammation, what are the events in acute inflammation, how the blood vessels, how the tissues are going to respond in case of an inflammation. Fine. Then we have also discussed about how the leukocytes are going to play a role in inflammation, how phagocytosis occurs, free radical concept, neutrophil extracellular trap. Fine. Yes. So all these are the, as you can see here, all these are the summary. Okay, this is the summary of what we have seen last class. Okay, summary of what we have seen last class. Fine. Once this is done, let us see. I have told you in last session itself, whatever be the events happening, am I right? Like vasoconstriction, increased vascular permeability, all those are associated, or it is because of some chemical mediators, we call it as cytokines or chemokines. Today in this session, I am going to discuss about those mediators in detail. Remember, mediators of inflammation is a very commonly asked essay question in your prof exams. You can get multiple MCQs in this session also. So, these inflammatory mediators are the substances which regulate the inflammatory reactions. We have the most important mediators. They are vasoactive amines, lipid derivatives like prostaglandins, leukotrienes, cytokines including chemokines, and complement activation or the complement pathway. The complement pathway, I will be just discussing the very salient features pertaining to inflammation. The rest of the things you can study in detail from microbiology. So, the mediators are generated either from plasma proteins, sometimes they may be also called as self-derived proteins. Okay, so the mediators are broadly, they may be either plasma-derived proteins, usually or most commonly produced from the liver, and cell-derived mediators, which are normally sequestered in the intracellular granules. Fine? Yes. Once that is done, see, please focus this table. This table is very important. What are the principal mediators of inflammation? Histamine, produced from mast cells, basophils, and platelets, cause vasodilation, increased vascular permeability. Prostaglandins and leukotrienes from mast cells and leukocytes, they also causes increased vascular permeability. Remember, leukotrienes also causes chemotaxis. See, C5A, what are they? Sorry, C5A and leukotriene B4 are chemoattractants. They mainly helps in chemotaxis. And we have something what we call it as prostaglandin. See, prostaglandins are mainly involved in VD, vasodilation, pain, then fever. And I am once again repeating this. The prostaglandin which is involved in pain, okay, that is prostaglandin E1. No worries, I will be mentioning this point once again. Then we have cytokines like interleukin 1. 3 cytokines you have to remember: interleukin 1, interleukin 6, and TNF, tumor necrosis factor. They are mainly produced from the macrophages. They also cause some systemic symptoms. I will come very soon. What are the systemic effects of inflammation? Okay. Then we have something called as the platelet activating factor. Of course, not only they are produced, they are mainly produced. So as the name indicate, platelet, but it is not mainly produced from the platelets. Actually, they are mainly produced from the leukocytes and mast cell. They also causes increased vascular permeability and vasodilation. And complement proteins and kinins, they are mainly produced in the liver, and they also helps in increased vascular permeability. You know, complement C5A. We have C5A, that is again a chemoattractant. And kinins, we have bradykinin, substance P, neuropeptides. All these are mainly involved in pain. Okay, perception of pain. So that finishes what to say, the principal mediators of inflammation. Okay. Then, so there are some characteristic features. Okay, they are not produced in a normal person. Whenever there is an offending stimulus only, these mediators are produced. Okay, and remember, they are very short lived. They are immediately degraded by the enzymes. Fine. Yes. So let us start with the first heading, vasoactive amines, histamine and serotonin. Out of that, as far as inflammation is concerned, serotonin have very less role to play. They are mainly produced from our mast cells, the platelets, as well as from the neuroendocrine cells of the GI tract. Okay, and whereas the histamine, the richest source are the mast cells. Fine, as well as they are also found in the basophils and platelets. And okay, how the histamine is released as a result of a process called degranulation. Okay, and as a result of physical injury or binding of antigen to antibody, this we will discuss in hypersensitivity reactions, as well as in case of products of complement pathway, that is C5a, C3a, they also trigger the histamine release as a result of degranulation. So what is the role of histamine? The histamine is considered to be the principal mediator of the immediate transient phase. I have told you, immediate transient phase, delayed prolonged phase, am I right? Endothelial contraction, direct endothelial injury, yes. The vascular events in inflammation, I hope you remember. Please, if you don't, please go that. It's a definite MCQ. Out of the 2 questions, any one question can be asked as an MCQ question in your PG entrance exam. So the principal mediator of the immediate transient phase is nothing else but the histamine. And remember, the histamine is going to cause the arteriolar dilation and venular permeability. Okay, this is very important point. Arteriolar dilation and venular permeability. Okay, these are the 2 important salient features of histamine. Okay, yes. So that is why in allergic reactions, okay, whenever you get some itching, okay, in allergic conditions you will be given antihistaminic drugs like CPM, chlorpheniramine maleate. Okay, fine. Then serotonin, I have already told, it is a vasoconstrictor, not that much importance in inflammation. Arachidonic acid metabolites, you have already remembered this pathway in your biochemistry, how the from arachidonic acid, these prostaglandins and leukotrienes are synthesized. If you are not clear, please take your biochemistry textbook. Okay, I will just give you a gist of the synthesis, but in detail, if you want, you can go back to your biochemistry textbook and you can see how the prostaglandins and leukotrienes are synthesized from arachidonic acid, which is a 20-carbon polyunsaturated fatty acid, which is derived from the essential fatty acids called as linoleic acid, alpha-linolenic acid, all those. So these arachidonic acids will be acted upon by an enzyme called as phospholipase, okay, phospholipase A2, and as a result of that, okay, you will have 2 phases. Okay, I will tell that once again. Don't worry, we will explain with that of a picture. Okay, so this arachidonic acid pathways, it has 2 major classes. One is called as cyclooxygenase, which is going to generate the prostaglandins, and the lipoxygenase, which is going to generate the leukotrienes and lipoxin. So how I used to remember? CP. Cyclooxygenase, prostaglandin, LL. That is from lipoxygenase, you have leukotrienes as well as lipoxins. Okay, yes. So the prostaglandins, they are produced mainly from the mast cells, macrophages, endothelial cells, all this. We have 2 types of COX enzyme, COX1 and COX2. Out of that, COX1 is most commonly expressed in various tissues, whereas COX2, it is expressed only in the cells which are participating in inflammatory reaction. Here comes the question. Out of COX1 and COX2, which is inducible? Answer is COX2. COX2 is inducible. That means normally this enzyme won't be expressed. Normally this enzyme won't be expressed. Fine, yes, it won't be expressed. Only in inflammatory condition this enzyme will be expressed. I hope that point is clear for you. Okay, done. So let us once again see how this arachidonic acid metabolites, what are their function. Please focus on this table. Prostaglandins, all prostaglandin, I2, E1, E2, D2, all this causes dilation. But very few prostaglandin like TXA2, thromboxane A2, leukotriene, C4, D4, E4 causes vasoconstriction. And the same C4, D4, E4 also causes increased vascular permeability. Already this has been asked as a PG entrance exam question. Okay, already this has been asked as a PG entrance exam question. Which of the following leukotrienes are mainly involved in increasing vascular permeability? Answer is C4, D4, E4. What is the significance of leukotriene B4? I have already told you B4, C5a, all those helps in chemotaxis. So I hope this table is clear for you. Okay. Let us go to this. This is a very important picture. Okay, and just suppose if they ask about chemical mediators, if you draw this picture, if you what present like this, what are the functions, what it is going to act, that is more than enough. So we have phospholipids which is present in the cell membrane, which is acted by the enzyme called as phospholipase A2, PLA2 I am writing, to generate arachidonic acid. This arachidonic acid has two fate, cyclooxygenase pathway, lipoxygenase pathway. From the cyclooxygenase pathway, we will be getting PGG2 first, then followed by PGH2. Can you know what is the enzyme here? Yes, PGH2 synthase. Yes, if you remember your biochemistry. From that we get PGI2, TXA2, PGD2 and PGE2. We have lipoxygenase pathway. From that we are getting 5-hydroperoxy icosahexaenoic acid. Okay, yes. So that is hydroxy-icosatetraenoic acid or hydroperoxy icosatetraenoic acid. That is the full form of that. And from that we will be getting leukotriene B4. Okay, which is directly from the HETE, that is hydroxy-icosatetraenoic acid. So leukotriene B4 is a derivative of HETE, whereas leukotriene A4, C4, D4, E4 all derived from hydroperoxy icosatetraenoic acid. You can go for the expansion here. It is given below. Hydroxy, it is B4. Hydroperoxy, it is A4, C4, D4, E4. Okay. What is this leukotrienes going to do? Bronchospasm, increased vascular permeability. Already discussed. So this is formed when 5-lipoxygenase come into action. Similarly, if the same pathway is acted upon by 12-lipoxygenase, you will be getting lipoxin A4 and B4. Remember, here comes the very, very, very important 5-star MCQ question. Which of the following arachidonic acid metabolite is anti-inflammatory? Out of all this given in this page, except lipoxins, all others are pro-inflammatory. They will what? Encourage the inflammatory process, whereas lipoxins are the only arachidonic acid metabolites which are going to stop, okay, which are going to give a halt to the inflammation. We have PGI2 causing I4 inhibition. That means it inhibits platelet aggregation. Thromboxane A2, A4 aggregation. A2 causes aggregation of platelets, vasoconstriction, and D2E2 causes increased permeability and vasodilation. Can you tell me now which of the following arachidonic acid metabolite is vasoconstrictive in nature? Option A, PGI2. Option B, TXA2. Option C, serotonin. Option D, PGD2. Yes, serotonin is not an arachidonic acid metabolite, but it is a vasoconstrictor. So we can rule out serotonin. I2, I means inhibition. It inhibits platelet aggregation. That means vasodilation. Ruled out. Again, D2E2, again it is going to cause vasodilation. So the answer is thromboxane A2. It is again a very, very important potential MCQ question. Fine? Okay. See, that's the same thing which is written here. PGE2 is responsible for pain and fever in inflammation. PGE2, very important. Okay, that's an MCQ. Leukotrienes, already I have told you, I am not going to explain more. Lipoxins, I have already told you, they are the only arachidonic acid metabolites which are anti-inflammatory. Fine? Oh, why we should know about this pathway? Suppose we can go back to the picture. I am using steroids. Steroids will inhibit phospholipase. So arachidonic acid won't be produced. So rest of the molecules won't be produced in inflammation. So can I administer steroids? Yes, good. If I use COX-1, COX-2 inhibitors like aspirin and indomethacin, you will learn in pharmacology. Okay, these are aspirin drugs, indomethacin, all these are the NSAIDs, non-steroidal anti-inflammatory drugs. These drugs is going to inhibit cyclooxygenase. It will inhibit the release of these chemical mediators. It will inhibit. That is why, while we have a fever, we are taking paracetamol. Paracetamol, all these acts by almost the same mechanism of action only. It is going to prevent the release of this arachidonic acid metabolite. And lipoxygenase inhibitor, leukotriene receptor antagonist, all these are going to inhibit this pathway. Hence, we can administer these group of drugs in inflammation. Fine? Okay. Then coming into some of the important cytokines and chemokines. I told you have to remember 3 important cytokines. What are they? Tumor necrosis factor, interleukin 1, interleukin 6. Out of this, TNF and interleukin 1 has a very important function. What is that? leukocyte recruitment, and migration. You know diapedesis, yes, that is the main functions of TNF and interleukin 1. Fine. TNF, all these are mainly produced by the T lymphocytes. Okay, yes. So the most important contributing role of TNF and interleukin 1 are, see, this has been asked as a short note question in your university. Role of TNF and interleukin 1 in inflammation. What is the role? You are going to draw this table. You are going to write a bit more in detail. Okay, yes. See, number 1 is endothelial activation. Endothelial activation means that E selectin, P selectin, everything, you know, you can write there. Leukocytes activation and systemic acute phase response. It is going to produce some systemic effect. What are the effects? Focus on these 3 pictures. If you draw these 3 pictures, you will be awarded 5 out of 5. Local inflammation, some systemic protective effects, systemic pathological effects. Local inflammation, this TNF, interleukin 1, all these are going to increase the permeability, increase adhesion. Endothelial activation. Fine? Yes. And this will further cause activation of leukocytes, which will further release interleukin 6. So, TNF, interleukin 1 will activate the leukocyte. This leukocyte is going to release interleukin 6. These 3, TNF, interleukin 1 and 6, acts on brain to produce fever, acts on liver to produce acute phase proteins or C-reactive protein, and on bone marrow it increases leukocyte production. And in heart, it may cause decreased cardiac output. In blood vessel, it will increase the vascular permeability, and in skeletal muscle, it may cause insulin resistance, and as a result, type 2 diabetes mellitus. This is a very important university exam question. You can't skip this. See here, interleukin 1, 6, fine, what is their function? These are all involved in acute inflammation. In chronic inflammation, we have interleukin 12, see here, interleukin 12, interleukin 17 and interferon gamma. Okay, yes, all these are mainly involved in acute and chronic inflammation. Here comes the question, which of the following interleukins takes part in both acute and chronic inflammation? Answer is interleukin 17. Interleukin 17 is one of the interleukins which takes place both in acute as well as chronic inflammation. We will deal about this detail. This interferon gamma, all these are produced by mainly macrophages. Don't worry, we will once it comes to that topic, we will discuss what are activated macrophages, what are classical macrophages, everything. Fine? Yes. Once this is done, we will see some chemokines. Chemokines are a family of small proteins. They mainly act as chemoattractants. We have various, see, they are classified into 4 major groups. Okay, based on the arrangement of cysteine residues. Number 1 type is called as CXC. What does that mean? You have one amino acid between 2 cysteine residues. Example for this is interleukin 8. They will ask you, which of the following is an example of CXC chemokine, CC chemokine, all this. Then second thing, CC chemokine, that means here there is no amino acid, you have just 2 cysteine. The examples of this is MIP1 alpha, macrophage inflammatory protein 1 alpha. Then C chemokines, that means it will lack amino acids as well as the rest of the cysteine. Example is lymphotactin. There is no concept to be understood here. Remember, there are 2 cysteine residues and some amino acid. Based on the arrangement, if there is 2 cysteine residues and an amino acid in between, we call it a CXC chemokine. Example is interleukin 8. Suppose if there is no amino acid, remove that X, what you will get? CC. Example is MIP1 alpha. No amino acid and 1 cysteine also gone. C chemokine. Example lymphotactin. Suppose if you have 2 cysteine, in between that if you have 3 amino acids, we call it as CX3C type. Example is fractalkine. Okay, I hope it is clear for you. Fine, done. Okay, let us then comes to what we call it as complement system. I am telling just, okay. I don't want to make you confused because it has to be dealt very in depth in microbiology. We have some complement. Complements nothing else but they are the proteins They're the plasma proteins which are produced whenever there is any inflammatory response. We have various pathway, classical pathway, okay, then what to say, alternative pathway and lectin pathway. Okay, just to see what is this pathway. Okay, as far as pathology is concerned, not that much significant. Okay, because if I tell now also, you won't understand in that much level. If you want, you can take your microbiology textbook. In immunology, the pathway is very beautifully explained in detail. Now I am going to say just only the very few points. Number 1, C5a, C3a, anaphylotoxins. They are called as anaphylotoxins. Okay, why they are called anaphylotoxins? Because they will produce effects similar to that of anaphylaxis. C5a, already told you, C5a is a chemoattractant. Very good. Then C3b helps in opsonization. What do you mean by opsonization? When the microbe, okay, when the immune system tries to phagocytose the microbe, this opsonins will coat the microbe. Actually, what we will tell, no, rather than eating bread alone, what we will use? We will use bread with peanut butter, jam, so it will make it tasty. So opsonins are the proteins which makes the microbes more tasty, so that the neutrophils or the phagocytes can phagocytosis very easily. Then we have something called as MAC, that is membrane attack complex. Please go and see you can see in this picture. Okay, we have the C3b, C3a, all these are the various complement proteins. Okay, they may cause inflammation, phagocytosis, and finally they form something called as a membrane attack complex. It is a group of complement protein which is going to engulf the microbe and causing lysis of the microbe. That is membrane attack complex. Whenever there is a deficiency in the complement proteins of this membrane attack complex, okay, it mainly causes what we call as Neisseria gonorrhea infection. Again, it is given in microbiology. Okay, you can focus on that. Suppose if there is something, what we call it as C1 inhibitor. Okay, what is C1 inhibitor? As the name indicates, it will block the activation of the C1, first complement protein. Suppose if the C1 inhibitor is deficient, it causes hereditary angioedema. Similarly, we have CD59 and decay accelerating factor. Okay, all these are there. If there is a deficiency of this proteins, what will happen? It will result in a condition what we call it as peroxisomal nocturnal hemoglobinuria. Okay, what is it? PNH. It causes PNH, peroxisomal nocturnal hemoglobinuria. Okay, fine. Yes. Then, okay, just I am not going that much in detail, because if I tell now, you won't understand. So I am not going to detail what is PNH, everything comes in hematology. First, if you want to have a good idea on that, as far as pathology is concerned, you just want to focus what are anaphylotoxin, what are opsonins. Again, this will be dealt in detail in microbiology. Okay, there immunology, right from the basics of the immune system, they will be teaching you. Please pay attention. You can very easily understand the complement system. Then come back and read this. Fine. Rest, what is it? Platelet activating factor, I told you already. Then what else? Kinins, yes. In pain, bradykinin causes contraction of smooth muscle, dilation of blood vessels, and pain. Bradykinin is a major mediator in pain pathway. Already you have learned in physiology. Okay, see here, final summary. Vasodilation caused by histamine, prostaglandins. All prostaglandin and which is the one arachidonic acid derivative which causes vasoconstriction? Yes. Thromboxane A2, very good, because it causes platelet aggregation. PGI2 causes vasodilation because it inhibits platelet aggregation. Leukotriene C4, D4, E4, vascular permeability. 3A, 5A, 4A, all those are called as anaphylotoxin. Out of that, C5A is chemoattractant, very good. Leukotriene B4, chemoattractant. Interleukin 1, TNF and PGE1 mainly causes fever, pain, bradykinin and substance P. Okay, yes. So, I hope, of course, all this, most of the things you would have learned in your basic physiology. It is just like a revision, okay, except the complement pathway. And I advise you to go through your microbiology to make it very clear. Fine? Yes? Okay. So I hope this mediators of inflammation is a bit clear for you, and very soon I will be having a very next session on what are the various patterns, how we have studied what are the various morphological patterns of necrosis and apoptosis. Similarly, we will be discussing soon what are the various patterns of inflammation. Okay, we have serous, fibrinous inflammation, everything, and very soon we will be discussing that. Okay, see you in next session. Bye.